Good evening, everybody. My name is John Aitken, and welcome to this very special event hosted by the Hunter Branch of the Royal Society of New South Wales. The latter is one of Australia's oldest learned societies, tracing its origins back to 1821. And it was granted royal assent in 1866 with a view to promoting scholarship in science and art, literature and philosophy, facilitating the exchange of information and ideas and disseminating knowledge to the people of New South Wales and beyond. The Hunter Branch, by comparison, is a relative neophyte. We were only established in 2019, but it has a very similar mission to provide information and stimulate debate, just like the one we're going to have this evening, on topics that resonate with our communities in the Hunter region. Before I do anything else, I'd like to acknowledge the traditional owners of the lands on which we stand and pay my respects to elders past, present, and emerging. In my case, that's the Awabakal people, but of course I acknowledge the traditional owners of all the lands that you are joining us from via live stream. So to tonight's topic. Tonight's topic is basically the aged care sector. As societies go through the demographic transition and become more affluent, two major things happen to their populations. Their fertility falls like a stone, and their longevity soars like an eagle. The result is that in the absence of immigration, advanced industrialized societies shrink and age. Ultimately, affluence drives the population age profile into the shape of an inverted pyramid, where you have a large mass of senior citizens being supported by the labours and indeed the taxation of a diminishing workforce. The other thing that happens in affluent societies is there's much less focus on the family as a default social unit. Marriage rates collapse, as they have in all industrial societies, birth rates decline, and procreation makes way for self-fulfillment as the purpose of existence. Because of these trends, it falls increasingly to government to look after its senior citizens and their dotage. So how is the government performing this very important role? Well, not very well, it seems. The havoc wreaked by COVID-19 will be evident to all of us. And a highly critical report from the Royal Commission into Aged Care tells us that all is not well. What should be done? That's the obvious question. And happily, we have with us tonight someone who is ideally positioned to provide an answer. Professor Kathy Eagar is Professor of Health Services Research and Director of the Australian Health Services Research Institute at the University of Wollongong. She has authored more than 500 papers on the Australia and New Zealand health and community care systems and received many awards as a result of her endeavours. And I'll just highlight two. In 2008, she was made Honorary Life Fellow of the Australasian Faculty of Rehabilitation Medicine, and in 2010, Honorary Life Member of the Australian Healthcare and Hospitals Association. Both of these awards being in recognition of her outstanding service to healthcare in Australia. She has been an advisor to the Aged Care Royal Commission and undertaken research into the adequacy of aged care staffing. So really nobody is better to capture for us the state of aged care in Australia and the performance of government in regulating this sector. Before Kathy takes the floor, I'd also like just to map out the rest of the evening for you. So Kathy's lecture will be followed by a brief panel discussion orchestrated by Professor Steve Weller, along with two highly distinguished guests, Max Thorpe, a gastroenterologist and medical writer with a particular interest in the aged care sector, and Marie Coleman, who is a much celebrated career, had a much celebrated career in the Australian public service, and indeed was the first woman in Australia to head a national statutory authority. So we have a stellar panel, a highly distinguished speaker, and an important topic to wrap our minds around. It's therefore my very great pleasure to introduce tonight's speaker, Professor Kathy Eagar.
Thank you very much for that warm welcome, and I wasn't quite sure what people might be interested in, so I thought I would start by both acknowledging the traditional owners and letting you know that I'm happy to share these slides. And what I'm aiming to do in my presentation is to be sort of broad, but not deal too much into too many things. So in the conversation, we can pick up on those things that are of interest. So I'm going to start with a little tiny bit of background about the aged care sector. I will talk briefly about the Royal Commission, and in my very kind introduction, you did make a point. I worked behind the scenes with the Royal Commission as well as doing research for the Commission. And I'm one of many who was very unhappy about the outcome of the Royal Commission, and I will explain why. I'm then going to talk about some major reforms. I'll talk first of all about residential care and then about community care. I'll mention some issues around governance and financing and then come to some conclusions that I hope we can have a conversation about. The first thing is context, and that's to say what we now spend out of government coffers, not what individuals spend, but the government now spends about the same on aged care each year as it spends subsidising public hospitals, and also about the same as the Medicare payments for Medicare under the Medicare benefit schedule. So it's not a trivial amount, it's about 25 billion, and this is how it breaks up. Basically, assessment and information services don't worry too much, but essentially it's 2/3 of it is spent on residential aged care and about 1/3 on supported home, and the rest is amounts of money for quality and whatnot. And this is from a couple of years ago, and there's been about 5 billion growth over the last couple of years. The government's intention is to progressively change the mix of investment from residential into home care, and I will pick that up in my presentation. The way the sector works now is that there's about 840,000 people who are getting what I call low-level support, and the Commonwealth calls Commonwealth Home Support Program. And for people who've been in the system for a long time, you would know that as Home and Community Care Program. And in fact, Marie Coleman on the panel was one of the people actually involved in developing that program. And that program is, cheap and cheerful, basically. It's about 3 billion now, and it's about $3,000 a person, 2,800 at the last calculation. So it's very modest amounts of money, basically a bit of housekeeping and things like that to help people with being independent. There's about 150,000 people getting higher level home care packages, and all the time you'll hear in the media the government talking about approving more packages for people. And that's about, on average, $20,000 per person. So the range is from 8,000 to 50. But you'll see there's a massive step up from CHSP, that is low-level packages, up to the next level. And many, many people on the wait list, probably 3/4 of people who are already getting a very modest amount of money through the Commonwealth Home Support Program. And in order to get any more, they need to move to a package, and I will describe that. And then there's about 240,000 places a year in residential aged care, and that's about $55,000 per person. So the Royal Commission went over 2 years, and the first report, in my view, was a terrific report, and they simply called it neglect. And they said, this is an aged care system that is failing to meet the needs of older, vulnerable people. They use words like unsafe and unkind. It neglects people. They were shocked and saddened. And that set up an expectation about what we might expect to see in their final report. 2 years later, they delivered a report. It cost about $100 million, 2 years of hearings. Interestingly, apparently this Royal Commission had the most public submissions ever received in a Royal Commission, 10,000 written submissions, 6,000 telephone submissions, most of those from consumers, either direct consumers or their families, describing how terrible the experience was. They didn't get very many good news stories at all, and they got a small number of submissions. And that final report went to government in February, and the government responded in May this year. So if anybody was looking for an elegant blueprint on how to fix aged care, you will not find it here. It is literally thousands of pages long. It is full of multiple volumes. It's full of inconsistencies. There's lots of conflicts and contradictions. Most importantly, the two commissioners clearly fell out towards the end of the report, and there's 148 recommendations, and about a third of them, they dissented from each other on what those final reports should. There's not a minority report because there are only two of them, But what they did, of course, was hand it to government on a plate when there are two of you and you disagree about a third of the recommendations. You really leave it to the government to pick and choose what they wanted to adopt. And of course, that is exactly what they did. The final report, I'm very critical of it, failed to do two things. One is it failed to actually address the problems it recognised in the neglect report. And the second is you get to the end and nobody can read that report and have any idea of what does a good aged care system look like. If we can't agree on what a good aged care system looked like and they couldn't paint a picture of it, it's hard to tell taxpayers we should all pay more for it. History, and I will come back to this at the end, but I think history will judge this Royal Commission as one that failed. And I would say that they got it right in the first half in neglect. Royal Commission, in retrospect, is designed to be, diagnose problems and errors. It's done within a legal and a regulatory framework, and it's done to assign blame or not. But aged care is really complicated, and it wasn't a matter of right or wrong. It's about values and social complexity. And I think, with the wisdom of hindsight, I would say the Royal Commission was not the way that should have been taken to try and fix aged care, because it didn't have enough public policy and it didn't have enough about social values. It was all about regulation. And most of the recommendations are about more regulation, because when all you've got is a hammer, every problem is a nail. And there's not enough attention to what do we value as a society and what are we prepared to pay for. And it really picks up that point about, there's no good picture of what an aged care system looks like. The government responded in the May budget, and they describe what they call 5 pillars, and they put 7.5 billion, and over 4 years this is, into home care. And that was essentially to fix what they see the problem as, which was waiting for home care packages. And they neglected the community home support program, and I'll come back to that later. They put another equivalent amount of money into making the residential aged care system sustainable by putting 8 billion into it. They put 1 billion basically into quality and safety, and that's good. We were very happy about that because the system is unsafe and unkind. They put some money into the workforce, and they put some money into governance reform, 17.7 billion. From a government perspective, that's done, they've done and dusted, and they want it all over before the next election. But note my comment in the box. There are 3 claims going to the Fair Work Commission towards the end of this year and into next year, seeking a 25% pay rise for aged care workers. And there's a very good case for that. Personal care worker gets paid less than somebody who works on a checkout in a supermarket. And if that was to happen, there is no provision in the budget to pay aged care workers a living wage. And it's the instability of that workforce, the fact that they're casual, the fact that they're poorly paid, poorly trained, is the underlying problem for a lot of the quality problem. So what did they do and how did the government respond? Well, the first group I'm going to call the low-hanging fruit. They have adopted the recommendation from the Royal Commission about a new act underpinned by human rights. They put more money into the system. They didn't put enough strings attached to that money, but they did put a lot more money, and it needed that money. I did do the research for the Royal Commission on staff ratios, and I was happy that they were adopted in the final report of the Royal Commission, and they did put a lot more money into home care. But I guess I'd make the obvious comment, we didn't need a $100 million 2-year Royal Commission to pick the low-hanging fruit. We all knew they were the problems before we started. The good thing was something was actually done about them finally. There are some promising elements in the response that the government put. I have to declare a conflict of interest. I was involved in funding reform of residential care. They have adopted our recommendations about public reporting. They have given it to the Hospital Pricing Authority to be expanded. They're getting 40 new staff to become the Aged Care Costing and Pricing Authority, as well as the Hospital Pricing Authority. And I personally think that's a good move. And they did do something, the Royal Commission and all the way through talked about individualised funding for older people And they kept envisaging, based on Canberra public servants telling them it was a good idea, that we should redesign the aged care system to make it look like the NDIS. And I'll pick that element up later. That's a disastrous idea. It's not working very well with the NDIS, and it would work even worse if it was in aged care. And the good thing is that right up until a few months before the Royal Commission reported, they intended to recommend that, and they walked away from a voucher system at the last minute. What did they miss? The first thing I think they missed is that in the first report, they actually understood that you can't meet the needs of older people unless you meet their health needs and their aged care needs at the same time. And they got that as an idea, but it was too complicated as a solution. So they treated aged care as a silo in their final report. The second is they really missed the opportunity for assessment, and they've actually proposed to abolish one of the few bits of aged care that actually works, which is aged care assessment teams linked to public hospitals, and they want to get rid of those. And they want to get rid of them because they want to get rid of the states and territories' role in aged care. They didn't come up with a new way of delivering community aged care that makes sense. There's ended up, they didn't do anything about allied health, and I think that's a really big shame. And they also didn't realise that the way you need to deliver human services is on a regional basis. You actually need a regional aged care system in the Hunter that works, and it doesn't have to be the same as the one in the Kimberley. And everything that they do in aged care, you get online and you go through the My Aged Care at the top, and you know, we don't run any other part of the human service system by making people get on a national queue, and yet that's the way we try and run aged care. So that's my overview. If I just step through a few of the issues, first of all, on the residential side, and I do want to start by just giving you an overview of the care needs of people going into residential care. There is a whole lot of rhetoric about there's all these people in residential aged care who shouldn't be there, and if we only provided them a little bit more support at home, they could stay at home. This is what the profile looks like for the people in aged care in 1920. And there's about 180,000 beds. And there's about 240,000 people who go through those beds each year. And the reason for that is that 60,000 people die and another 60,000 take their place. There's a lot of people who've been in aged care a long time, but there's also now a cohort who are literally going into aged care in the last few months. And the average life expectancy from entry now is 2 years, an entry at 85. Interesting, if you look at the age sex profile, in the young group, and I'll call those the under 75s, it's about equal numbers of men and women. And as you go up through the ages, what you see is the men dying out and the women going on to live very long lives. So that 64% of all the people in residential aged care are women. And I thought you'd be interested in that top little group. There's 4,300 people in Australia now who are over 100 in aged care, and the oldest group, there's about 12 of them, they're all 108. So we've got a very old population, 85 now at entry. That does look different to 20 years ago, and it's because people don't want to go to aged care, and they're not going there for lifestyle choice. They're going there because they don't have a choice. And we see that in the frailty profile. One of the studies I did was that we independently assessed, we employed our own assessors, expert nurses and occupational therapists and physios. We independently assessed 4,000 people. And if they were terminally ill, we removed them. That's why that little group down the bottom doesn't have anybody. But you'll see that we're talking about only 2% of people described as fit and 3% as well. Those groups, they actually, all of that group have very severe dementia, but early stage, and that's why they're so physically well. But you'll see it's a very, very frail population. This is what people look like in terms of the help they need, because we were interested to understand whether there were people in residential care who really could be at home if you gave them a little bit more help. Over 80% of people need help, can't get themselves dressed without help. And 80% of people can't toilet and groom. And once the food is set up for them, 2/3 of people still need help with eating once somebody else has actually cooked and set up the meal. So that for me is, these are measures of real dependency. This is the same sort of measure. Bladder and bowel management is the first two. And then the last is get mobility transferring in and out of the bath or in and off the toilet or getting between a bed or a chair. And we're talking about 70% of people needing help with that really basic tasks. And we do have, I think, a community rhetoric that, you know, the children are very selfish and they put their parents in residential care because they're too selfish. But I think we need to really start to look at the dependency level of, you know, one of the prices we're paying of success, of longevity, is a cohort who are extremely frail. A lot of the language in aged care is around consumer-directed care and empowerment and individualisation of funding and those sorts of words. And 2/3 of people in residential care need help with communication and expression. And 80% of help need help with cognitive functioning, so memory and so on. Very needy population. If I move now to what the Royal Commission recommended and what government adopted for residential care, the way the system works now for residential, for those who are not familiar with it, is that there is 3 funding streams. The first is you pay for your accommodation, and you pay either by what they call a RAD, a refundable accommodation deposit. You pay $500,000 or whatever, and your family get it back when you leave or die. And the home gets that money and uses the interest and keeps the interest. And that was lucrative for homes when interest rates were high and not worth much to them now. Or else you pay daily rent, and that's all paid by the resident. The second is your board and lodging, or what they call the basic daily fee. That's paid by the resident, and that is set at 85% of a single pension. It's currently $58 a day. And homes can charge extra, and most of them do when they can, for extra services, and it's very hard to know in lots of homes what you're getting for that extra money. For the very first time in the May budget, the government actually put some money in towards basic daily fee, and it was really because of the campaign that was run about the quality of food, and they put $10 in for the very first time. And then the third component is funded solely by government with no consumer contributions, and the current funding model, which I'm not going to talk about, but is called the ACFI, the Aged Care Funding Instrument, and the new model, which gets implemented next year, is called the Australian National Aged Care Classification. And that's the classification I developed. But I do want to just note that's the care area where there's a lot of contest about what's the boundary between aged care and healthcare. This is how the ACFI works now. And you get assessed, a person gets assessed according to 3 domains: activities of daily living, how do you manage those sorts of things I just showed you, any behaviour problems, and then complex healthcare. And the more problems you've got, the more money the home gets, and the homes do the assessment, so they've got all vested interest to find every single problem with you. And if you're high on every domain, that is, you need help with activities of daily living, and you've got behaviour problems, and you've got complex healthcare, then the home gets paid about $100,000 a year. And that includes your basic fee, and you've paid just the pension part. So the major recommendations in residential care were, not surprising, it was a Royal Commission run by a bunch of barristers, lots more rules, lots more regulations, lots more reporting. Big investments in quality systems and all that stuff. Not sure that any of that's going to hit the ground, but it will certainly make homes more accountable. There is, as I mentioned, the new aged care funding model. They have adopted staff ratios, and that's around total minutes and nursing minutes, and that was based on our work. And they have adopted a recommendation around moving to 5-star public reporting, so a sort of as for consumers to use. So we're reasonably happy about that. In terms of community aged care, it's a mess now, and I'm not sure they're going to get it any better. They are proposing to roll 4 programs into one. So one is the old HACC program, support program, and then packages. And there's also transition care, and there's also some things called residential respite. And they're going to roll that into one. And I just thought you'd be interested in this, because this was what happened behind the scenes at the Royal Commission. They knew that they had a problem because they had too many programs, and they got a team of advisors who'd previously been public servants in the health department who devised the current structure to devise a new one, and that was in December. Guess what? They came up with a model that looked pretty much like we already had. Then they got sold the idea that consumer choice is going to fix the system. We'll assess everybody, we'll give you a voucher and you get a $40,000 voucher and you get a $20,000 voucher and you can go off to the marketplace and you can buy the aged care you want, which is pretty much the voucher type systems we've seen in the privatisation of VET and childcare and a range of other areas. And all of that's based on the idea that competition is going to improve efficiency, and somehow or other choosing your aged care is like choosing a new fridge. And right up until November 20, and just to remind you, they reported in February 21, they really were sold on this idea that the way to fix the system is to introduce even more competition and hand people vouchers. And by then they actually recognised that if you actually did that with a population of very frail older people, there were potential for exploitation was just massive, and that it wasn't actually going to increase competition anyway. The problem was that by the end of that, by the time they got to that point, the Royal Commission was almost at an end. The commissioners were in outright conflict and they couldn't actually agree on what should replace it. So they ended up writing this stuff, which is a bunch of words, which basically says, oh, we'll leave it to the people in the health department to design the new community aged care system. So that's still now a work in progress. There is no plan for community aged care. There's going to be a federal election between now and when the plans are, are supposed to happen. I keep saying to people in the community aged care sector, you might as well get in and have a say about what you think it should look like from a government perspective. All they're happy about is that they believe they've fixed aged care. They've thrown a lot more money at the quality and safety of residential care, and they've thrown a lot more money at the community wait lists, and they think they're the two big problems. And I don't believe the government's going to die in a ditch to defend anything that might be planned for community aged care, because I don't think they really care. So I guess there's an opportunity for people to try and look to Labor to see if they might have come up with something and at least have something to debate for in terms of a new election. They have proposed a new program called Support at Home. They're proposing it won't start until the 1st of July 23. It does merge those two programs. They do say that contributions, that is co-payments from consumers, will continue, but they don't say what they should look like. And they've introduced lots more rules and regulations for them as well. And I won't bore you with them, but there's new changes for governance arrangements, and you've got to have a board of directors, and people actually have to get training to be how to be a board member and basic things like that. New standards, new data, a code of practice, mandatory registration for care workers. It's just been a joke, this stuff that we've had recently about every care worker has to be vaccinated when there's no registration scheme, and the government doesn't know either the numerator or the denominator. It doesn't know how many personal care workers we have in Australia, and it doesn't know how many of them are vaccinated. So the government has commenced consultation on critical elements of a new program. They are beavering away to design a new assessment system because they want to get rid of ACAT, and I totally oppose that. They are looking at how to develop a new payment model based on bundled payments. They're genuinely trying to work out how to increase choice for consumers. And they're really struggling, I think, to do that. I think they're well-intended, but I think they're naive. They are trying to get better case management for people, because they do know that there's lots of people who have real problems making decisions and who are really vulnerable to being exploited by unscrupulous providers, of which there are very many. They have finally worked out that we need to do something to better support informal carers, that is families, and they're looking at how to better support early intervention programs to help people stay at home for longer. There's a lot of really good ideas, but I'm not overly confident because the devil's going to be in the detail. If I just think now about governance and financing, I would say the most fundamental governance problem we've got is that there's a big schism between aged care and healthcare. Commonwealth is responsible for aged care, the states and territories are responsible for healthcare, and there's nothing in the Royal Commission report or in the government response that actually fixes that. And in my second dot point, I've got a whole lot of services that I think older people really need and which should be integrated into their aged care, but somehow or other they're all separate. Things like podiatry and dental care and getting access to pharmacy and getting access to medical specialists. And that's because the system's designed in two parts. And there's a real question in my mind about whether you can fix aged care when you've got aged care and healthcare being responsibility of different levels of government. In terms of governance, the two commissioners really split on this issue. Commissioner Pagoni, who was a tax lawyer by background, so government, his assessment was that the government was the problem. Aged care was a mess because the government hadn't managed it properly. And the way to fix that was to privatise it essentially. So he proposed to take it out of the hands of Canberra Public Service, but he also proposed essentially to take it away from the hands of government. And he took it out, he wanted to take it out of the normal policy process and he wanted to set it up as a Commonwealth authority, but essentially to privatise the governance of it as well. And he also proposed to uncap expenditure on aged care, that whatever was needed to provide aged care, that's what should happen. Commissioner Briggs, being an ex-head of the Public Service Board, saw government as the solution, and she wanted to leave it in the health department and she wanted to tinker with it to improve it, and she proposed things like a National Council of Elders. The one thing she did share with Pagoni was that they both wanted to uncap expenditure. Surprise, surprise, government backed Commissioner Briggs, which is hardly surprising. So we haven't really got any fundamental reform on governance. Mind you, I didn't actually think Pagoni got it right. I actually wrote a different alternative proposal that neither of them liked, but I didn't think that the privatisation of governance was the solution either. So I think that's more or less, they've reached an impasse on that. I do want to just mention funding, because this was a really fundamental but unresolved issue for them. They actually proposed in the report that aged care should be regarded as a universal entitlement, that funding for aged care should be uncapped, that taxpayers should fund most of it, and I should just say taxpayers fund about 80% of it now. When they said there should be no co-payments, they were really saying taxpayers should fund 100% of it. But they really argued that if it's a universal entitlement, then you're entitled to whatever level of public funding is required to meet your need or your demand. They didn't ever define need. And the government basically rejected outright, or just remained silent, that whole package about what to do about financing of it. I had a problem with that whole idea, and I did call it aged care and the magic pudding, because I'm old enough that I could remember the magic pudding, because I was really concerned about equity, and I was concerned about it from two issues. There are many, many people going into aged care who've got little or no savings, and they do need to be fully funded by the taxpayer to live a good life. But we are also now the richest generation in human history going into retirement, and there are people who are going into retirement with millions, with superannuation. You know, the last election, the vocal older population demographic was much more concerned about franking credits than they were about aged care. And I was also really concerned about intergenerational inequity. We are the richest generation. The young people coming through now who are going to have to pay the price of rebuilding the economy in the post-COVID world, are we really saying that they should be paying for everything that everybody wants who are in old age? So I think we've got to try and find that balance between an aged care system that's affordable and responsive to the needs of older people, but doesn't impose an inequitable burden on young people who are the taxpayers who are going to have to pay for it. So in conclusion, I've got, I mentioned before, I really do want to just say, I think history will judge it as the Royal Commission that failed. And I think it failed essentially because I can't tell you what a good aged care system looks like, having ploughed through their 1,000-page report. And if I can't tell you, government can't tell you. And more importantly, there's no picture for taxpayers of what are we asking you to pay for. I would describe what the government did is that they picked the low-hanging fruit. They threw $17.7 billion at it. I think they failed on three really big issues. The first is that we need to understand, I think, that aged care should be seen as a public good like Medicare rather than a competitive market. It's not like buying a fridge. It's like, from my point of view, going to get essential health care. The second is we can't just, they did not, and they rejected explicitly my recommendation to regulate profit. Commissioner Pagoni said that would reduce competition if we regulated profit. So I don't think they've done enough about funding accountability, and I don't think they did enough about better integration of health and aged care. This is my final slide. I think we need to come back and say old lives do matter, and there's 5 bits of that. We need to think about what do people need in terms of living, to live their best life. What is good healthcare look like? What is functional care like? Helping people with activities of daily living. What are social needs and how do we meet those? What are residential needs, but also what are palliative and end of life needs? Because we actually need to be planning for that whole life cycle for older people. Thank you very much. That's all I wanted to say.
Kathy, thanks so much for that presentation. I have to say, with my mother on the fringes of the aged care system, it's a very personal presentation for me. We have 2 panelists, Marie Coleman and Max Thorpe. I wonder if I could open the Q&A by just reminding our audience that we have the ability for you to ask questions in our system. There should be there's a Q&A link at the bottom of the page, and should you click that, you'll be able to enter questions that I can farm out to our panelists. But I wonder if I could open by asking both Marie and Max to give their take on Kathy's presentation just briefly, and then we'll facilitate Q&A from there.
Look, so much of this debate is incredibly familiar. When the Hawke government came to power in '83, Don Grimes was the Minister for Community Welfare and Social Security, and he inherited an aged care mess. And he was extremely anxious that we reform aged care. He was very much involved, of course, also trying to get young disabled people out of the nursing home system. That was one of the key things that he was concerned about. But we'd already begun work on looking at measures to stop the unconstrained growth of the private sector, private for-profit nursing homes. And so much of public policy back since then has gone backwards and forwards about that. What we did do was bring in the original aged care assessment teams, which were to be cost-shared between the Commonwealth and the state. We also set an extremely sophisticated, that's my little bit of irony, cap on nursing home beds. That is to say, we calculated the number of nursing home beds already in each region and said that was the cap. That there weren't to be any more beds, that beds could be substituted for new providers, but that was the end of the beds. And we tried to make sure that the aged care assessment teams made sure that the people who were going to go into residential care were indeed, as we used to say in the language of the 80s, bed-centred. So we were already trying to stop the lifestyle discussion. The HACC program, as we set it up, I had already begun work on the HACC program before the change of government, and that was essentially about bringing together all of the different programs that were scattered between health and social security, which related to home care, which weren't fitted together at all. It wasn't thought of at that time as the low-cost one, it was the one. It was the only thing. And there was a lot of restructuring went on around that time. Now, the changes which took place under the Howard government in the sort of 90s essentially let the private sector rip again, I think, to a very large extent. And we're paying the consequences now of that. We've still got aged care assessment, which has meant, as Kathy so eloquently pointed out, that the people who are going into residential care are in the main, really very frail. You know, this nonsense when people read these ads about come and live at something or other, and it's all full of lifestyle bollocks. That's not the aged care sector. So we have an urgent need to rethink all this. Now, one of the other things that we were doing towards the tail end of the Hawke government was bringing in American social welfare people to talk about how we could substitute more intensive home care for residential care, trading off. And I think there were very early thoughts about that. And you see that eventually emerging in the home care packages systems and so forth. I won't try to draw comparisons with the American system, but Kathy's absolutely right. That split between what are health needs and what are social needs has been there for the past 50 years. We don't seem to have been able to resolve it. It is true that there's a lack of planning as between what the Commonwealth pays for and what the state pays for, but it's also there that Commonwealth Health, for all its faults, has had very little role in the development of aged care at the federal level. It's nearly always been in the social portfolio, and it has, as Kathy's pointed out, moved increasingly towards this fascination with consumer choice, which, speaking as an 88-year-old, is actually not actually where most people my age or a bit older are at. But Max, over to you.
I enjoyed Kathy's talk. I thought that she was bang on. She understands the topic. She understands the problems, and I think she also understands why we're unable to solve the problems. I'm going to make a couple of outlandish, not outlandish, but different statements. Our group, we call it the think tank. We are more concerned with the, not with the process of aged care, but we are more concerned with the structure. And the structure is wrong. The Aged Care Act says that the government is in control, and it's also responsible for the financing. And that has been a very backward step. Marie mentioned the Howard government coming in, and that was the start of the providers having their little picnic. The providers were clever enough or fortunate enough to be able to siphon some of the funding away from the people it was intended to into their pockets. Now, that didn't come up during the Royal Commission. I was disappointed that it didn't, but it was certainly a major factor in the failure of aged care over the last 23 years. So the next item is, and Kathy didn't touch on this, the Department of Health we see as the bad guy. We think that the Department of Health should be removed from all association with aged care. Its record over the last 23 years has been abysmal. It's not interested. Their appearances before the Royal Commission were very disappointing also. And we are of the firm belief, and I'd like people to think about this, we are of the very firm belief that whilst the Department of Health is responsible for the delivery of aged care, it cannot succeed. I'm prepared to answer any questions on that and give you the reasons why, but for the Commission, for the government, and that's the important thing at the moment, the government has to decide what they can pick out of the commission, if they pick out anything. The government has to decide which of the two they want. They don't want Pagoni because it's private enterprise. They cannot have Commissioner Diggs' suggestions. It's totally, she's gone totally government regulation, and with her suggestion, there is a grave fear and a grave doubt that it will succeed, and then we would have a double calamity, wouldn't we, if we were responsible for putting in charge of the delivery of aged care an organisation which has previously failed. Thank you.
Thanks, Marie, and thank you, Max, both. We do have a couple of questions in our chat box, and the first one's from Susan Pond, who's a president of the Royal Society of New South Wales. Thanks, Susan, for joining us. Susan's question, slightly controversial, is: did the Royal Commission consider voluntary euthanasia, and what is your view on this?
I'm happy to start. The first bit's really simple. No, the Royal Commission didn't consider it.
No.
The second thing is, I think we should be focused on helping people live their best life. And we actually know that we know from in all the internationally that less than 1% of people dying a predictable death actually elect voluntary assisted dying. It's the biggest beat up. There's this assumption that everybody's out there and given the option would take voluntary assisted dying. We actually know, we know from the Victorian experience, but we know particularly from Canada that given the option, you know, the estimates for Victoria were that about 400 people a year out of their 40,000 deaths would elect voluntary assisted dying. And that is pretty much what the number is. And a very small number of those, in fact, I actually met last week with a nursing home who's actually had 2 residents choose voluntary assisted dying. And they said, look, these people are very, very frail. They were at the end of their life, and what they thought they were doing and were doing was shortening their life by weeks to months, not years.
Thank you, Kathy. We have another question, and it's from Phil Waite, and Phil sort of phrased it in language that I might use myself. He says, Phil says, and this is a question to Kathy and Murray and Max alike. I'm a newbie to this info. What's the most critical issue in your opinion?
If I could wave a magic wand and say what is one thing I would do to fix aged care, yep. I would actually introduce regional aged care authorities. There would be a Hunter Aged Care Authority, and it would sit next to the Hunter Health Authority, and there'd be local planning and local ownership, and you'd be given the opportunity to design an aged care system that meets the needs of the people in the Hunter. And I wouldn't try for one size fits all. And I think the one size fits all problem, the fundamental problem is we have one My Aged Care gateway to get. Imagine if the way you got into a health centre or the way you got into a childcare or the way you got into university was that we all had to go and get on one queue. And from my point of view, what works in the Hunter will never work in the Kimberley. And if I could do one thing, I would regionalise the whole of the aged care system. And at the local level, I would have a local aged care board that has local community reps and aged care providers and consumer reps to design a tailor-made local system.
Yep. Wonderful. Thank you. Murray?
Well, I'd support that too, very much so, because that is going to be the point at which you're going to have much better capacity to look at what the needs and existing resources are in the local community. Long distance stuff doesn't work. And you would have to give a regional body like that control over the allocation of resources and the capacity to approve new residential settings, quite obviously, which might have to go back to authorities at a higher level. But that seems to me to be central to managing what you want to do, whether it's in the Hunter, whether it's in the Illawarra, whether it's in the southern region. I spent a lot of time a few years ago working up in Cape York, and some person who meant well I think they meant well, had insisted on setting into Hopevale a very large regional aged care home. Now, the local people in far north Queensland were not going to send all their people to Hopevale. And in fact, the Hopevale aged care home was mostly used as a substitute for a local guest house for visiting people coming in and out, except that the funding model didn't support it. But it was quite ridiculous. It was an inappropriate central government decision to put that kind of facility, which wasn't relating to the health services in far north Queensland. It was a ridiculous decision. Regional planning is really central.
Wonderful. And Max, if you,
Yes,
Kathy,
I would just like to add that I think a lot of home care, which constitutes 90% of the aged people, can be organised and done within the community. That's my particular area of expertise, working with the Sydney Community Services, working with the local council, being on a committee which is planning aged care, and working with our think tank, a group of very intelligent, very motivated people to come up with ideas. And we're gradually looking towards an answer. And the next step which we're going to take is to introduce a management and delivery program for aged care. That'll be done professionally. We've got the guidelines, we're attacking it, and I believe if you can have something which can be a guide or a hallmark to settle down the governance and the delivery of aged care, that would be a start. Now, having established that, you would then move to the next building block in terms of what it is that you're going to add to it, and it would refer back like you are. The management and delivery has been prepared by an architect, and he's got a blueprint somewhere up there which you can follow, but you don't really know about that, but you will have that guidance. Now, that might sound a bit obtuse and a bit ambitious, but I think that we should go back to the basics, leave the community in charge of the aged care in the community. Of course, they will do it better and they'll do it well, and you don't need much government interference.
So mindful of the time, we're 3 minutes away from top of the hour and done, but I have a follow-up for each of you briefly then that follows immediately from that. The question again is asked by Phil Waite, which is this: why can't we have that? What's an impediment? Give me one impediment to that. Why can't that happen?
If I knew the answer to that, I probably wouldn't be here. No. I can't answer it. There should not be an impediment. I think that my aged care is the greatest impediment. That just frightens off the older people. The second impediment is the doctors are not joining into aged care. They're deliberately avoiding it. So the next step is to get the doctors involved. The third step is to get the community involved, which will be done within our local community, which consists of the aged care facility, consists of the PHNs, the private health networks, consists of the local councils, it consists of the local mayor. They can basically organise most of home care.
Thanks, Max. And Kathy, I think you had a response.
My regional idea is at two levels. One is the commissioning and funding and planning of services, and the other is the way that an individual navigates, and that is that we actually have to make better use of GPs. When people need aged care, the first person they go to is their GP. They don't go and get on a national queue. So, you know, there are vested interests now at the Commonwealth. The Commonwealth treats aged care as a funding program, just like applying for Centrelink benefits. So from their point of view, you're applying for a Commonwealth benefit. You're not actually applying to get a bunch of services. And that's an important distinction. And until they actually realise that aged care is not a finance, they want to run it like Centrelink. Mm-hmm. And that's because that's what they know how to do, because that's what the Commonwealth does. They don't do human service delivery. And until we overcome that problem, we won't solve the aged care problem.
Wonderful. Thank you, Kathy. We have 1 minute, Murray. I'll give you the last word. What's the impediments to the regional aged care?
Well, Kathy's right. Until we get some agreement between the relevant funding bodies that they will accept a regional structure, because the state health systems are extremely important. We've got Commonwealth individually funding doctors through the MBS, which is not given to regional planning. And we've got this ridiculous MyGov stuff. I don't want to even go there at the moment. There has to be some coordination, but it will require an agreement by both state government and the federal government that regional planning and a certain degree of pooling of resources is going to be central to that process.
Wonderful. Thanks so much for that response. It actually ties very nicely into the questions we don't have time to answer, but that were asked in one of the chat forums. And both those questions were around the role of state and federal governments in the way forwards. But we are out of time, and with that, I'll hand back over to John for a vote of thanks.
Okay, thanks very much indeed, Steve, and an enormous thank you to Kathy for such an informative, entertaining, and fundamentally worrying lecture. And thank you too for Max and Marie for such an entertaining and informed discussion. Clearly, the suggestion that aged care services should be dealt with at a regional level is something which there was some consensus around, and certainly something that resonates with me. I certainly learned a great deal. I think the frailty and dependency of the aged care population was a surprise to me, and the need for integration with medical services, allied health, mental health, certainly very apparent. And I guess the fundamental problem for us is something I mentioned right at the beginning, that given the changing age structure of our population, an uncapped system is clearly untenable. So how do we achieve the aged care system of our dreams? How are we actually going to pay for this, and how are we going to So these are rhetorical questions. I think we're not going to answer them tonight, but I would again like to thank Kathy, Max and Marie for their wonderful contributions. And thank you to everybody who has tuned in on the webinar. Thank you all. Thanks, Steve.